All right, welcome back. We are very pleased to be joined by a very special guest today, Dr. Stephen Lapke, who is the medical director here at Limitless Male Medical. Doc, welcome.
Thank you.
How you doing, Doc?
Great.
Good to have you on, man.
Yeah. Nice being here.
Oh, yeah.
Yeah.
Thanks for having me.
Yeah.
Today's topic is going to be around preventative medicine. So, Dr. Lapke's got a very credible, very impressive background, which I would rather have you, talk about some of your background. But and a couple of the things that led you here, some of the ideas and goals that you had around your own medical practice over the years, and how that aligned with Limitless Male Medical. So we're delighted to have you here, and we're going to pick your brain on some things. And I wanted to kind of get a little bit of your background, if you want to fill us in on where you came from. And
Absolutely.
Yeah.
I grew up on a large farm in Iowa. We raised a lot of cattle and then corn and hay. Everything that we raised went to feeding the cattle. But it was just a great experience, great way to grow up. We ran it more like a ranch. So as young as I can remember, I was on horseback and working cattle. But my dad was, I feel, very influential in my life. He was one of those jack of all trades and could do anything. I mean, he was a mechanic, so he took care of all the mechanical work on the farm equipment. Construction guy, he built our farmhouse from the ground up, did everything himself, and just had an incredible work ethic. And I think really instilled in me that blue collar work ethic. And so after graduating from high school, I moved to Omaha, and I wanted to stay home and farm, but at that time it was in the early 80s when there was a real farming crisis going on. A lot of farmers not doing well, bankruptcies and whatnot. So Dad really encouraged me to go get an education. So off I went. Did my undergrad at UNO, and then went to medical school at University of Nebraska Medical Center. And I think here's where my being raised on a farm and my blue collar mentality came in. I was just always wanted to be one of those doctors who could kind of do everything, like my dad, be a jack of all trades. And I feel that primary care and ER, out of all the fields of medicine, have that most blue collar, just hardworking, get it done mentality. So looking back, I think that's why I kind of went that route.
you get your hands dirty.
Exactly.
Yeah.
Exactly.
Very
We're in
dirty.
the trenches.
Yeah.
Yes.
Yeah.
Yes.
Yeah.
So I did my residency at Clarkson Family Medicine, which is a private program. And at that point, that's when Clarkson Hospital was still a private facility. And so we were the only residents in a rather large hospital, so we got great training. Early on, as soon as I could, I took advantage of moonlighting and went out into a lot of the rural areas even as a resident, and worked long weekends in the ERs and really got my hands dirty and really fell in love with the challenges of emergency medicine. So even though I trained in family medicine, right out of residency, I took a full-time ER position at then Midlands Hospital in Papillion. After a couple of years, I still had the desire to run my own practice. And so I did open my own primary care practice down in Bellevue, and had no patients, had to go to the bank, beg for a loan.
Sure.
Started up, but in no time at all, we were full, and I had just short of 4,000 patients.
Jeez.
By 2007, I was still working ER as well, and really became frustrated with the business model. I mean, nothing like running your own practice to really, see what works and what doesn't work. I had multiple employees. I had my own in-house billing. I think we had privileges at almost every hospital, so we were doing rounds, seeing patients in the clinic, in the hospital, etc. But really became frustrated with the whole, what I call insurance model of medicine, and where you have to have a lot of staff to manage a lot of different things, to have contact with the insurance companies to get prior authorization for certain tests, to get approval for certain meds, and just to help your patients understand and manage their insurance and what's getting paid for and what's not. So I felt that even though I had a big practice, I couldn't spend the time with my patients that I wanted to, and I couldn't affect them in the way that I really wanted to, which I would believe was, spending more time really getting back to the basics of healthcare, and be able not to just throw medicine at them and expect there to be great changes. I wanted to impact them in more meaningful ways. So out of that frustration, I did close my practice in 2007 and then just went back to full-time ER. At that point, I started my own independent contracting business and began contracting with rural ERs. I found out there's just a huge unmet need, and it served me incredibly well to this day. I've worked at countless facilities throughout Iowa and Nebraska, really turned into a road warrior, putting on about 35 to 40,000 miles a year on my truck. But, just was in some of the greatest communities, met great people. I saw more disease, trauma, etc. in the rural communities than I ever even saw in Omaha.
Really?
And because you're it. I mean, everything comes to you.
Yeah.
And there is no trauma team or, this specialty or that specialty. You're it, and you have to manage it, triage it, and you have to ship a lot of patients out, and you hope you do it well and do it in a timely manner. So, it was a huge learning curve for me, and just a really good experience. But again, in ER, it's what I call sick care, which really is the mindset of healthcare in our country.
In general, it's
yes.
Yeah.
It's not, let's take care of this beforehand. It's, well, I'll come see you when something happens.
Right.
And really, I mean, the insurance reimbursement is set up that way as well, right? We don't really get reimbursed for any kind of prevention. We don't get reimbursed well for sitting and spending time with patients and sharing knowledge. We get reimbursed for doing things and prescribing things.
Right.
Yep.
And that's not the best model. So while I was doing ER, my passion for a different type of medicine, I would say, even grew more. Out of frustration, out of seeing how flawed the system is and how, poor outcomes were, et cetera. So in 2019, my wife, Brooke, and I, Brooke had, her training was, she was an EMT in her earlier life, then went to radiology school and became a radiology technologist. Worked at Children's and then worked up in Denison, Iowa, and then managed the department up there. So she had a lot of just good general medicine experience and a lot of IT and business experience.
That's big for business.
That's big for
Or
business.
running your own business,
Yes.
rather. Sorry.
So we had similar passions. So it's like, let's start our own concierge practice in Papillion. That's a community we live in. And so she was my business manager. I was a doctor. And just the two of us were able to run that clinic and do it very effectively.
You cut the red tape.
Cut all the red tape.
I don't think people understand. Like I try to, and I don't mean to cut you off, Doc, but I think
No, you're fine.
like some of the things that we think about, the cost of healthcare, people are just so up in arms about the cost of healthcare. One of the things that people don't understand sometimes when you talk to them about this, because they're always complaining about how much money doctors make and blah, blah, blah. It's not the doctors. If you look at inflation and the cost of healthcare, the wages of physicians are actually going down.
Yes.
While they make the same money, it's not enough to keep up with inflation, right? So they're actually losing money year by year. But if you look at the bloat of corporate medicine, of administration just in a hospital, which is the vast majority of the employees in a big hospital system, it increases. But the same amount of doctors that come in are the same amount of doctors that go out. The same amount of nurses that come in are the same amount of nurses that go out. Same with PAs and NPs, right? So it's just kind of a revolving door. You don't get more doctors and more nurses and more nurse practitioners and PAs. They're all on the level, right? And we always talk about how there's a shortage of all of them everywhere. Well, there's not a lot of incentive to get into it because you just get drowned in the bureaucracy of medicine. And so, the cost of healthcare could be cut dramatic if we had less regulation. And I don't mean like, hey, let's just go cowboy up and do all this crazy stuff to our patients, but there's so much red tape from a Medicare, Medicaid standpoint they have to cut through and worry about and be concerned about, that the people who really lose in the end are the patients. They don't get the care that they deserve to get. And it's super frustrating. I mean, you see that in the ER of people who just use the ER as primary care because they don't have insurance. But with EMTALA, you have to see them.
Right.
So the concierge model is so attractive for doctors because it allows you to charge a lower rate and you can help your patients get the medications and the treatment that they need, and they can reach out to at any time. And you can, I mean, coming from a small town, like, yeah, I mean, like, you probably saw the local doc at the ball games and at the store and say, hey, how's your kids doing? And they knew you, they had a relationship with you. It wasn't just like, hey, how you doing? You look at your blood pressure, okay, all right, good to see you. Now the nurse case manager's going to come in, take care of everything, and then we'll see you in 6 months, right?
Absolutely.
That's a terrible way to do patient care. So sorry, I didn't mean to go off on that. I mean, there's probably going to be 8 other times I'm going to do that in this conversation.
It's exactly what he was talking about before we started recording, because I was brand new to concierge. He had to explain it.
It's
to
a
me.
beautiful
the same
thing, man. It's a beautiful thing. You'd be surprised what you can accomplish when you put a good doctor with and I don't even want to say like a business manager. It's more of just like a clinic overseer to help with the day-to-day operations to make sure that he can do his job effectively. Whereas you get these big organizations that are like, well, how can we squeeze every single dime we can out of insurance companies to make a profit? Medicine is the biggest industry in the country. It's bigger than tech. It is massive, massive, massive. But there's also hospitals that'll sue their patients if they don't pay their bills. They'll take them to court and sue them. You're going down the street, right? You can't afford insurance. You get hit by a car. They drag you into the trauma bay. They do $100,000 worth of work. And you're like, well, how am I supposed to pay for this? I don't care. You can pay us $1 a week until you die, or we can sue you. And some institutions will sue their patients, man. It's incredible.
Wow.
Yeah.
Oh yeah. That's been I've read more articles about that in the last couple of years. It's a huge issue, huge problem.
Yep.
And yeah, Josh, you're exactly right. As I was saying earlier, I mean, concierge, the concept of it comes back to putting all the emphasis back on the provider-patient relationship. That's it. That's what it's about.
Which is likely why you got into it in the first place.
That's why all of us got into it, because we wanted to make a difference. We wanted to help people.
Yeah.
You know, we wanted to have time to spend with our patients, to do what we are best at. But when you're limited on that and you become almost robotic in nature and cookbook-like, then that really robs you and the patient out of all the passion and fulfillment of the art of medicine is gone.
Yep.
And if I understand you right, the incentives that you were talking about in the model that we just went through is that the incentive there is to go fast and see a lot of people, and to also you're incentivized to push products and to push drugs.
Absolutely. Well, our whole training is about pushing, like writing scripts, ordering tests, doing things to patients.
Mm-hmm.
That's what most of the emphasis is, because that's where the money is.
Mm.
That's where the studies come from. And that's where the education comes from.
Yeah, it's tough, man. You get between a rock and a hard place really quick as a medical provider, so there's people who have like chronic back pain, and they're like, okay, well, we got to do an X-ray first, and they're never really explained clearly as to why that's the first step. It's not, that's what I want to do. I know you need an MRI, dude. Right. I know you need an advanced image where I can see or a radiologist can see your spine from 360 degrees and millimeter slices through the whole spinal column But your insurance company wants to see if they can maybe find something on an x-ray that we can use so we can treat based off of that instead of just cutting to the chase and getting to the MRI. So I'm going to make you come in and see me. Then I'm going to make you go get a separate x-ray, and then I'm going to make another doctor look at that x-ray, and then I'm going to look at it again and tell you, okay, great, now we need an MRI. Now you got to come in another week later, sit in an MRI machine for an hour. Then that same radiologist will read that report again, right? Then it'll come back to me, and then I'll refer you off to a neurosurgeon who may want to do more imaging after that. And then you've had 6 different cooks in that kitchen when you can just cut it out and say, hey, I'm going to send you here, and then I'm going to send you to Dr. Rick, who's the guy that I always refer on my neurosurgeon. Like, you could cut out so much of that, but all that stepwise crap is for insurance companies.
Wow. That's
a lot of people don't understand that. Yeah.
What I see happening now in the emergency room, and it's rampant, that a patient will show up at their primary care office. They potentially have something significant going on. The primary care physician knows that he cannot get authorization to order said tests. Let's say it's abdominal pain. It's like, I know this patient needs a CT scan. They can't get prior authorization fast enough. So they go from their primary care office straight to the ER, strictly because they know we can order the test without prior authorization. So it's driving everything to the ERs.
right.
So they can, it's playing that game, and it's how do we get around it? And that's how much the insurance companies dictate care.
And then the back end of that problem is if primary care doc says, well, let's see if we can get the test tomorrow, or we'll try to get an ultrasound in a couple days, and that person has like a perforated bowel, and then they become septic and die. Guess whose fault it is? It's the doc who said, well, my hands are tied, I got to wait a couple times. I don't want to send them to the ER every single time. And so then doctors have to practice defensively. They don't get to be, I guess you'd say, offensive, or just practice the way that they believe they should be able to with patients, because then they get defensive and they get scared because they're going to get litigated upon if something happens.
Well, yeah, he's in a rock and a hard place, right?
Yep.
He's in between, I need to care for this person, and I see that there's an issue, but I can't have the delay occur because there could be some potential hazard here.
Yep.
And
Not
I'm
to
at
mention the
risk.
liability, yeah.
Yep.
Right.
Mhm.
Holy shit.
I mean,
Okay.
the amount that, like, for me as a PA, I generally get covered under the organization's insurance, but doctors have to carry their own liability. It's outrageous how much they have to pay for insurance.
Wow.
Outrageous, just to protect themselves.
So, because of all that, I mean, that again just drove my passion more for, there's got to be a better way. We have, in a lot of ways in medicine, we got to get back to basics. We have to do more prevention, which I don't necessarily like that word. Josh and I were talking about this morning.
Yep.
I think, Josh, what was the term? You had a better term for it.
I don't know. I don't know, proactive care or offensive med. I don't know how you would put it, because
Progressive health.
You said progressive.
I think that's
before,
probably
yeah.
the best term, because
Yeah.
preventative sounds like we're not trying to make you a healthier person. We're just trying to protect you from getting sick. I think the connotation there gets a little goofy, because then preventative still implies that we're going to just do stuff to you,
Yeah.
instead of allow you to help yourself by doing the right nutritional and exercise and so on and so forth.
It's like, let's take you beyond prevention, and let's get you so healthy that, that you're not going to potentially, or your risk is so low to succumb to this disease or that disease, and you're living the best life that you can be. It's not just about, like I said, preventing disease. It's really about getting you to the healthiest place you can be. And I don't care if it's mentally, physically, and that's really what healthcare should be about.
Yeah, it is. People don't like that term, whole person or holistic. Sounds so, I don't know. It puts kind of a new age twist on it, but when you look at it, it's the whole person.
Yeah.
So if we're focusing on a whole person, we're looking at their mental health, their nutritional status, and what limitations they can have within that, and how we can potentially help with that. Their physical lifestyle, their overall living situation, right? So if we don't take all those factors into account, we can't generally manage a full patient to make them healthy and whole. So it's a really interesting dynamic and issue that doctors run up against, that you just don't have the time. Like, you don't have the time, and you don't have the resources because you're so boxed in.
Yeah. I've read studies, there's enough concierge practices out there and enough patients now that they're able to gather enough data. But studies have shown that patients of concierge physicians, they have less disease overall, less hospitalizations, better outcomes. Well, why do you think that is?
Yeah, it's more integrated.
Yeah, they're getting, those doctors know them more intimately, more time to spend with them,
Right.
more time to really not just prevent disease, but make, very positive changes, get them to their best.
Yeah, and before we started to record, you were talking about getting back to the basics, with nutrition and fitness, and he covered a little bit, be more comprehensive, being whole. What are some other things that are involved? I mean, because preventative medicine or preventative care, I guess, in some sense, can be pretty broad, right? And that's good because it's not so transactional and just dealing with you and then on to the next one, right?
Mm-hmm.
So, what are some other areas that that come up or that are important?
Well, I really believe nutrition and exercise or activity are really at the core of keeping us at our healthiest. I mean, you think about it, if we have a high performance vehicle, we're not going to put, poor quality fuel in that system, oil or gasoline, right? We're gonna spend the money. We're gonna put the highest quality, or things are gonna get gummed up and not work properly. And it amazes me in our society how little of an emphasis there is on that. I mean, I can say from a nutritional standpoint, like in my medical training, I got next to nothing.
I hear that a lot, actually.
Josh, I bet you would say the same.
No, it's a pretty low yield. I mean, I think we did maybe an afternoon on nutrition, and it was mostly inpatient nutrition than it was actual like lifestyle. And I think the frustrating thing about that is the society that we live in now is so obsessed with credentials, and if you say one thing that's maybe not, that was true a year ago but isn't now, you're obsolete or you're not credible. And so people are like, well, I go to a dietitian, and it's like, well, I mean, that's great, but like I could spend a lot of time and teach you about nutrition, on how to eat healthy, at regular intervals that work for your body, because it's not just one size fits all. It's not a high carb diet. I mean, we talked about this, man, in our diet episode. Refer back to that if you'd like to know more of how we feel about that. But there's a reason why there's 25 different diets out there, and there is a little bit of trial and error in that. And I think people just need to know that, like, okay, you don't have to stick with this one. If you feel like, if you're bloated and you feel tired and you feel foggy doing this diet, well, it's probably the food that you're putting into your body. Like you said, you don't understand how people have the tolerance to feel that way.
Right. Yeah.
But if they're told by a dietitian for one 15-minute consultation, and I'm not trashing dietitians, I think they're great. I think they need more time with people too, right? Yes. They need more access and more time to be able to adjust people's diets, and they're a great part of an interdisciplinary team. But it gets really frustrating when we can't, again, use that part of it, and it's got to be so quick, and everybody wants a quick fix, and we fall into that habit.
Yeah. If you're going into people's homes, you mentioned it, and that's what you were talking about before. You're going into people's homes, how they live, it affects their mental health. Obviously, that gives you an opportunity to see what their diet is like, what conditions that they're living in. That's a completely different experience, patient doctor wise, than is, okay, I'm in here for a few minutes, and I know I got patients that are lined up out the door. So yeah, just watch your cholesterol.
Yeah.
It's like, that's a very narrow, I mean, it's a totally different approach.
Watch what you eat, because I hear that all the time in clinic. Well, I'm watching what I eat. Yeah, me too. I was like, shoveling into my mouth. Yeah, I watch all the food that goes into my mouth.
Or just statements like, we just need to eat healthier. What does that mean?
Exactly.
I'm sorry, I don't have the time to go over that with you. I mean, that's our broken medical system. So when Brooke and I started our concierge practice, it was a priority for me, and I did a lot of research and a lot of interviewing. I found a nutritionist that I felt had probably the healthiest approach to eating and nutrition that I had found. And she was in our office and seeing patients. I recruited a strength coach who came in to the bay next to me and put up his own gym and is working with adults and is very much into, adult health and very knowledgeable in that aspect. We were made to move as human beings. We were made to be active, and we were made to eat healthy, not eat a lot of the junk that is in our current diet.
Well, right. And in our episode, we talked about that being unique to you, and that would be unique to me and unique to him. And it's not buy it in a box or fits in a box, right?
Yep. And I think the hard part about the diet portion too is that, like what you said, we're made to eat healthy and made to move, is that our evolutionary mind is in a mode of like, I need to consume, right? Our brain is designed to do that, to say food could be scarce for the next 2 weeks, so I'm going to load up. But then it's like, and I don't want this to sound bad, but like our access to food at any time is almost a bad thing. Well, it probably is a bad thing. I shouldn't be nervous about saying that, because we shouldn't have access to 1,500 calorie meals 3 times a day, because our bodies just do not need that much food.
Correct.
Right? Unless you are like, I guess if we're talking about just a base need, right? Olympic athletes need more calories, but like we don't really need that stuff. I mean, like we don't need that to live and to get by and to survive and be healthy. But I think the access and the ease of access to food, to be able to drive through somewhere and get as many sugary calories as you can handle, it has caused a pretty big detriment to our society, and the fact that we just work jobs that we are encouraged to basically not move for 8 to 10 hours a day.
Yeah, fundamentally, we're wired feast or famine.
Yep.
Absolutely.
Yep.
Yes.
Yeah. And we have access to feast almost all the time.
Right.
Yep.
Yeah. That's crazy.
But, in our current medical model, I know I keep going back to it, but we do not have the time to educate in that capacity. And that's incredibly unfortunate, and you're seeing the outcomes of it. It's no coincidence that we have a epidemic of obesity in our country.
Yep. And then when it comes to time, right? So the issue of obesity leads to cardiovascular problems and diabetes and metabolic syndromes, which then lead to orthopedic issues. And it's just this devolving problem, right? And it's the same issue like in a workplace, as in 10% of the people cause 90% of the problems at work, and same thing, 10% of our patients suck up 90% of our time. So if I have to see a patient who is obese, who has diabetes, who's in heart failure, who's depressed because they are in that situation. So I've got 10 different things I've got to spend time with this person. Aaron's waiting for an hour and a half in the waiting room. He's a young, healthy guy who exercises, who's just here for his annual visit. But maybe he's got a little bit of depression that he's been dealing with, or maybe he's feeling really anxious and he can't really fight through it just through what he's doing. And I come in and talk to him, Aaron, how's everything going? Well, I got to go back to work in 10 minutes. Everything's good, doc. I'm just checking my blood drawn. Blood pressure's good. I'll see you later. And so then, again, that's part of your holistic care that I completely whiffed on just because I didn't have time to do it, or you didn't think I had time, or you had to be someplace else because the lack of ability to manage patients ahead of time, again, the progressive medicine to prevent that patient from doing it, sucks up so much time, energy, and money that it doesn't allow for the people who kind of have these hidden issues that aren't really at the forefront of mental health and other things, which can devolve and lead to bigger issues down the road.
And at a certain point, so you opened up that concierge practice in 2019, and at a certain point, I mean, that was very important to you, that was how things were structured, and it's because it's about the patient and doctor relationship, which of course that's the right way to go. I think we all agree on that one. But there was something that really aligned you with Limitless Male and what they do with their patients. I'm presently a patient, and I have been for a year and a half. I can attest to that personally. My brother would say the same thing. Josh sees a ton of patients. So it seems like this is a real marriage of, fundamental mission, right? About helping men and getting them on the right path and doing it in a number of ways because there's a real care around that.
Yes.
And there's time spent around that. So what does it mean to you to be here, and what are you most excited about what this clinic and Limitless Male is doing for men?
Well, When Dan Malloy first approached me, I was at my practice, and as I learned more, what Limitless Male was about, I did begin to see a lot of similarities in the fact that their focus, our focus, now that I'm medical director, is on health and not just prevention. It's definitely on making men be all they can be. We're at our best, we're in our 20s, 30s. And that's the reason for that is everything's normally functioning quite well. And one of those most important things is our testosterone levels are at their highest, although we're seeing more and more gentlemen in their late 20s and early 30s that have very low levels. And again, I think that goes back to our society, our eating, our environment, etc. But they have a real passion for treating men and helping them to be at their best. Testosterone therapy, I call it a foundational hormone. It is what makes men men. And when it's not at its proper level, we start to have a breakdown of our system, and we get advanced aging and a multitude of other problems. And I mean, that whole philosophy certainly aligned with my philosophy in medicine. And how can you most impact people in the best way possible? And I felt that that's what they were doing, and doing it extremely well. And so to me, it seemed like just a natural progression for me of my medical career and the next step and how I can impact the most people.
One of the things that I know this line of work is always up against is sort of the stigma around the business itself, which is that, okay, you see something like a commercial or an ad about, male hormones and testosterone. Almost instantly, there's this knee-jerk reaction, or there's this perception that it's a negative connotation, or that it's, egotistical or maniacal, or the big guy at the gym. And it is so fundamentally flawed because, just as you said, when at a base level the hormones are off, there's a multitude of issues. You're going to know, you guys would know it better than I am, but, what would depression, lack of energy, lack of, sexual performance, lack of sexual interest, your relationships decline, your work performance declines. These are things that we cannot afford to have happen, especially when we have families that are looking to us or people that are looking to us to be relied upon because we need to be outgoing and achieving. You're an entrepreneurial spirited guy. Obviously this is probably something that was, you were destined to find. So as you kind of like look forward and, the clinics continue to open up, what excites you most about being able to help men?
When, I've only been with Limitless for 3 months. I mean, Josh could speak to this much better than I could, but I have been astounded at the number of men that I've seen already that come in, and I always ask them, how long have you been on therapy, and what do you feel that's done for you? And I have heard some of the most inspiring stories I've heard in all of my medical career.
Wow.
And I graduated medical school in 95, so we're talking a lot of years. I've had guys say it's saved their life because they were having health issues. I've heard them say it has saved them financially because they were struggling so severely in their jobs and getting through the day, they felt like they could hardly function. I've had men tell me it saved their marriage. I had heard the most amazing story last week. 71-year-old farmer from Iowa who comes in to Josh's clinic every week, and he has been on testosterone therapy at least for a few years. He continues to farm full time, plus he runs other companies.
I think that's a trucking business.
Trucking
If I'm
business,
picking up, yeah.
And
Jeez.
he said, I am more in love with my wife today than I was when we were dating. And we have a more intimate and stronger relationship than we ever had. And I know none of that would have been possible. Like you said, I know testosterone has gotten a bad rap because for years, obviously, it was a product that was
Black
black
market.
market.
Yeah.
It was abused. I mean, if you abuse anything, if you abuse Tylenol, you'll go into liver failure and die.
It's a bad way to go to.
And yeah,
You know that personally? or-
I've seen it.
Sure,
I have
yeah.
seen it.
but what's so frustrating, there's been obviously an emphasis on women's health for decades, which there should be, and on menopause and hormones and the effect of them and the benefits of them. But for a long time, men's health, it was like, well, that's just the way it is. That's just aging.
Just getting old.
But it came at a high cost to our society, and it still does. Because as you were saying, when our testosterone levels are low, the effects are profound, from psychologically to physiologically. And it affects jobs, it affects productivity, it affects relationships, it affects marriages, it affects families. And, that's at the core of what makes us who we are in our country. And that's how much emphasis and how important I think what we're doing is.
The introduction for, or I guess the attention to the female hormones. I mean, they get introduced to, sort of doctor care or I mean, much earlier, probably in their teens, right?
Oh, absolutely.
Yeah. So it's much earlier where
Yes.
guys were like, okay, unless it's broke or falling off, or unless I'm bleeding or leaking somewhere, then maybe I'll go and check up.
Yeah.
But other than that, I'm good.
Yeah.
Well, that's not super preventative, let's say.
Right.
And it's also not really looking at maybe what may be boiling underneath the surface, because these things decline slowly over time.
Yes.
So
And sometimes rapidly, like I said, we're seeing younger guys
Yeah.
come in with this,
Oh,
right? So it's like, I think that was the thought, and I think kind of what our practice has allowed us to do is a little bit of a thought experiment, because we'll have guys of all ages come in, and we're not going to treat somebody who doesn't need it. But I mean, you'll see guys who are 27, 28, and they'll come in, their testosterone is low. And we kind of investigate why, like, what are you doing? Is there something that you're doing that you shouldn't be? So on and so forth. And they're like, dude, it's been like a year and a half. Like everything was great, like last summer or like last Christmas. And now I'm tired all the time. I'm miserable. It's affecting all the things that we've kind of been talking about. I would really be interested to like pull that data if we could. That would be a nightmare, and actually really kind of get an actual good range of normal testosterone levels and to see kind of, because I don't necessarily know, because at first we were kind of taught it was like about 40 things start to slow down, and now it's more like we think it's 30. But is that really true? Is it more like 25? The societal pressures are much different now than they were even 30 years ago, on young people specifically, and how is that affecting our hormones? Remember, the production center is the brain, or the signal center is the brain. And so if we're constantly under high stress and anxiety or depression or substance abuse because of those things, how is that affecting our hormones? So I think there's kind of a dual approach that we can take when you're talking about, like, we see young girls, right? Because they start their period when they're young, right? And then they have it until they don't. Once they run out of eggs, then they go through menopause and they're miserable. And then we kind of treat as we can from there. So there's this kind of a lifelong thing that they've got to deal with. Guys, it's kind of like, great, I got hair in my balls, and then we're going to go, and then my hair starts falling off my head, and then I just keep getting tired, right?
Yeah.
We're just a little more, we're quite a bit more simple to the core from our physiological standpoint as men. But what can we do to stave off low testosterone and hopefully get it back? Because I just think the generations before us were built a little different challenges, different expectations. And I think just it's a really interesting kind of, I wonder really if we could kind of figure that out, if it's much younger than we thought it was, and how we can, again, use our progressive medicine to prevent that and then treat it when we need to.
So beyond the stigma that I mentioned, or the mountain, I guess that a business like this faces, you're also faced with the admission of it, right? So that would be like, okay, yes, I'm going to admit that I have a problem, so I have to lay down my pride and go and admit that. So if you had a chance to to speak to a younger generation about the importance of this, what would you tell them?
Number one, in regards to that, yes, there's always been this kind of it was taboo to talk about, this hesitancy. Of course, part of that has to do with us being men and our egos and our pride, right?
Yep.
I do think I know, like, over my medical career, it has gotten significantly better because of the education that is out there. Now, we have a long ways to go, don't get me wrong, but it's far better than what it used to be. And it's more acceptable to talk about it, and there's more advertisement about it and more education. That's a great thing. But it's like anything in health, as you were saying, it's very important to identify it at a younger age, because we don't know for sure, as Josh was saying, when do you really start to decline?
Right.
And it's like anything else, blood pressure disease. If you don't catch it early on and it's just kind of creeping up over years and decades, by the time you catch it, you've already got so much damage from it. Or diabetes. Same with testosterone. As our levels are going down, then that's causing advanced aging, advanced inflammation, advanced breaking down of certain systems. You don't know how many years of productivity you lose, how that affects you financially, the quality of your relationships. I think it's critically important to find out where your level's at when you're younger. I've told my sons and son-in-laws who are in their early 20s, you know what, go get a baseline. You feel like you're at your best. Let's get a baseline, see where you're at, and so you have something to gauge it on. And then every few years after that, or as symptoms arise, I think it's just important to monitor testosterone levels as it is your lipid levels.
Yeah, and the younger generation is going to be more prone to, oh, this guy at the gym said that he could get me this, or I know I can get these pills at GNC. But that's assuming that you know what the baseline is, and you don't.
You don't.
If you don't know what because there's an optimum level, or there's a level that you should be at, or that you should hope to attain to be on a fairly regular basis, or that's what you would be striving for, I guess. But if you don't have any sense of that, it's a moving target. Mm-hmm. So you could be taking way too much. You could be taking some things that have adverse side effects, mm-hmm. That are not approved in any way or administered safely. So the baseline is huge.
It is. Yeah, and I would ask you, Doc, what do you think prevents primary care doctors from doing those types of things and monitoring testosterone levels here? Because it's a dirt cheap test. It's like $3, $3 or $4. It's not like it's an expensive.
They don't want to talk about it.
Well, number one, it's just a lack of education, a lack of knowledge. I mean,
and not by any fault of their own.
No. I mean, it's our medical system. I mean, think about when you went through training. How much education or emphasis was put on that?
We just learned the pathway. With all the enzymes and the pictures and the chemical and the nightmare of trying to regurgitate that. That was about it.
And I as well. I mean, there was just no emphasis put on it. Mm-hmm. So you don't know what you don't know. And I think it starts there with, like I said, education's improved, but it has a long ways to go. And that starts with the medical community, not just even the general public.
Yep.
And I think also stigma. You still see and hear physicians out there. I have patients tell me all the time, I went to Dr. So-and-so, whether it's their primary care specialist, and they're like, oh, you're on testosterone therapy? I wouldn't be doing that. It's dangerous. And I'm like, did they tell you how they thought it was dangerous? No, they just said it was.
Yeah.
Yeah. And because I'll hear patients say, well, my doctor said it's bad for my heart, or it's can cause cancer. I'm like, okay, that's a statement. Now prove it to me, right? We live and work in evidence-based medicine society, right? If you make statements like that without the ability to back it up, then you're the fringe one, right? If you can't bring me, because that's the thing, if somebody brought me like a bunch of papers that said like, yeah, man, you're putting your patients at high risk for coronary artery disease and cardiovascular events and strokes and prostate cancer, like, first of all, who in the FDA is allowing me to do this? That would be the first thing I would ask. And the second thing I would have to do is introspectively ask myself if I'm going to continue to do that to people, right? So like, there is not really any good evidence that shows that those statements are at all true, right? Now, there is some anecdotal stuff that says that, but let's kind of dissect that really quick. So you look at old school bodybuilders, a lot of those guys started dying because they were having heart attacks, right? And they do these autopsies and advanced cardiovascular disease and enlarged hearts. Okay, so even with that, now anybody who is worth their salt in dissecting data or anything like that, what else were they on? What dose were they taking? Was anybody monitoring that? How was their diet when they were on the treatments, right? Because a lot of these guys eat pounds of red meat and high carb diets when they're trying to bulk
Thousands
up.
of calories.
They look great for about 4 days, and then go find them when they're in their off season. They look like a really big dude, right? Yeah. So, and people don't. I mean, that's the problem when you just don't want to peel back the second or third layer of that onion and then be like, oh, yeah, I guess that kind of makes sense. Well, yeah. And guess what? We're not doing any of that, right? We keep guys on one agent, right? And we give some stuff to prevent other side effects that help. We monitor their labs every single month, and we make sure that they're squared away with their doc and they know about it. And if there's anything that comes up, you're done. Go see your doc. Come back when they think it's safe for you to get back on treatment if there's any other issues that arise. So that's the other thing that needs to be done, our due diligence as providers, to make our patients feel comfortable that we're looking out for them, and to loop their primary care doctor, or if they've had a history of heart attack or cancer, to loop those people into it also, so that they're aware of what they're doing. And then we get pulled in as part of an interdisciplinary team. Right. So it's
to do the whole,
the whole patient care.
I would be willing to bet that men come in and they're on 5 or 6, 7 medications. Maybe that's a little far north.
No, I mean, certainly there's a number.
You're not far off.
Okay. There's a number of those out there. I mean, and the older they are, the more comorbidities. Absolutely, they can easily be on that many.
And let's also talk about a lot of the patients that we see don't go to primary care doctors, but they want to come and see us.
Yeah.
So that's another window of opportunity for us as providers to do stuff, to take care of them, to help them.
So they're on basically what they're getting meds for, those 7-8 meds. Aren't those like, could they potentially be treating just a side effect of having an imbalanced hormonal experience? Meaning, are we not? Is it not being treated at the base layer?
Now I'm not going to go on record and say, "Hey, come and get on testosterone, and you're going to get off all your."
For sure.
Yeah,
you know what I mean?
Not true. Yeah, that's a pipe dream.
But it does go back to, if we are more aggressive early on in managing people more appropriately, the majority of the common diseases that are most costly and cause the most disability and death can be prevented.
Yep.
Which is your diabetes, your vascular disease, etc. So, and if testosterone is what it takes to keep you at your healthiest, keep you active, keep you productive, there's going to be benefits of that. I've read 2 studies lately. One looked at a large population of men. For men who had normal testosterone levels versus those who had low, significantly increased risk for all causes of mortality for the men who had low testosterone levels. All cause. Wow. And that was in the American Journal of Endocrine.
Yeah, it's a big one.
Big one,
by the way.
This is for endocrinologists. I mean, that's what they do, right?
Yeah. COVID, of course, big issue.
This is a really interesting.
Yes.
I've read this study.
A recent study, they looked again at men, those who did well with COVID, meaning they stayed out of the hospital, didn't have any long-term effects, versus those that hospitalized, placed on a ventilator, who had death from COVID. again, a statistically significant difference. The men who had low testosterone had a much higher risk for hospitalization, ventilation, and death from COVID versus those who had normal testosterone levels. It is a foundational hormone, and it affects us at the cellular level.
Yeah.
When you talk about the weak, frail, crabby old man, they have low testosterone.
Yep.
And when we're weak and frail, we're susceptible to diseases, disability, and death.
Yeah, and I think an interesting thing that I always kind of bring up to patients when I'm helping them out and we're talking and treating and talking about what we're doing, why we're doing it. If you look at if you take a side-by-side comparison of low testosterone symptoms to depression symptoms, they're almost an exact mirror. They're almost the exact same thing. In fact, they might be pretty darn close. Lack of energy, lack of interest in things that you used to find joy in. You're not sleeping well, or you're sleeping too much or not enough. You're irritable. You are depressed, right? More days often than not. We see patients like that all the time, right? Every single day we see patients who come up with those exact same complaints. And we'll see patients who are on antidepressants with the exact same complaints, right? Mm-hmm. And so I'll tell guys like, hey, like we'll start to the testosterone, we'll see how you do, and then go from there, right? Guys who aren't on antidepressants who come in with that, I tell them, hey, this could potentially have a depression aspect to it, right? You've been feeling like this for the last 4 years. Someplace you're going to get in a deep, dark hole. We're going to start the testosterone now. If things aren't getting better or we're getting marginal gains, right, then we'll talk about, do we need to maybe add an antidepressant? I've done that for a few guys, and it takes them over the top.
Wow.
You fix the hormonal imbalance and you fix the brain chemical imbalance, and guys get significantly better. There's a place for all that stuff, right? I just think that the hormones are the first place to look rather than starting guys on something that's going to tinker with their brain chemistry.
Right. That was my point about, are we digging at the fundamental or the foundational level, or are we just kind of like, popping the balloons that are basically side effects of what's actually happening.
Yeah.
Right.
And it's so easy to treat, right? Yeah. Like
especially in that old model.
Yeah.
By the way.
Oh yeah.
But you start guys on testosterone, and within, let's say, like 3 weeks, they're feeling significantly better. That's not everybody, but that's a significant portion. But sometimes you'll start patients on antidepressants, and that doesn't work because they have bad side effects. So you got to switch them to another one, and then that one didn't work, and then we got to add a second drug because we're not kind of like it gets into this. Okay, we've been at this for 6 months. We haven't looked at people's hormones, right? Hormone is a base level thing we should be checking, like you said. That's a part of our body. It's part of our physiology. I can measure serotonin levels. I can't measure how well they're being uptaken into neurons and the effect on that. And am I going to really do functional MRIs and spend thousands and thousands and thousands of dollars when I can do a $4 test? Holy crap, man, your testosterone was 180. Yeah. Oh my goodness. Well, maybe we should do something about that. Holy doc, I feel so much better. Because I've had guys get off antidepressants and all that stuff because we fixed, any imbalance in our body causes us to go haywire. And I don't think people appreciate that really until they feel it. So
I don't know what you think, Josh, but exactly. I mean, when you're talking about the psychological component and mood and their improvement in their life, enough emphasis is not put on quality of life in our country, and particularly in medicine.
Yeah.
It's like, it's easy to poo-poo that. Well, that's just subjective. But I'm telling you, we have patient after patient after patient after patient who comes in and tells us how profoundly this has affected the quality of their life. Mm-hmm. There has to be value in that.
Yep. Yeah, you can't just sit in it. You see patients who are old and frail in the hospital who are 83, and it's like, great, you outkicked your coverage, but like, how you doing? Like, you've been like this for the last 7 years. Is that worth it? And I guess like if you had a candid conversation with some of those people, they'd probably tell you no. But our guy who's 71, who's out there still planting and harvesting, and he's weaning, he tells me, I got weaning the calves today. I got to get in and get out of there fast. And it's just like the greatest thing ever. I'm like, man, I hope I'm you and I'm 71. Yeah. I don't know if I could do it right now. It's like, he's a machine. I mean, those just, again, I think it's just he probably lost a little bit of that, and we got it back for him. Because he's out there with his son and his grandson, right, on the family farm, and he's still kicking. 71, not just like, hey, I'm just gonna. He's working with those guys.
Yeah. He's living.
Yeah.
Yeah.
That's a great. I don't know.
He's not just existing. He's living.
That's a quality of life.
He's 71 years old, farming, in the middle of the country in Iowa, 20. I mean, that's awesome. I love hearing that stuff.
I think we've only scratched the surface here, Dr. Lapke, and obviously we're going to have you back on. We really appreciate you coming on today. There's no reason to suffer in silence. Men, just grab it by the horns, like lay down the pride, go get a baseline, go check it out. There's nothing wrong with it. There's actually millions of people that have the same issue. And you would be better if you were in the camp that would just deal with it. There's no reason to suffer in silence at all. So I'm deeply grateful as a patient of this place to what you guys do and what really brought you here, which is the patient and doctor experience. So thank you so much for your time. I hope you'll be back. We're going to have you back. But,
I'll definitely be back. I appreciate you having me.
Yeah, absolutely. Well, that's going to do it, fellas. But thanks for listening, and we'll catch you next time. Cheers. Yep. Hey, guys. Thanks again for joining us on another episode here at Men Explained Podcast. If you're watching this on YouTube, go ahead and hit that subscribe button. Also, the bell icon as well, so you can be notified when we push out new videos. If you have any questions, comments, or concerns, go ahead and drop them at hosts, that's plural, HOSTS, at menexplainedpodcast.com, or just visit our website, menexplainedpodcast.com. Thanks again.